Hello, everyone. It's a pleasure to be here with you. I am Elisa Brietsky, and I'm going to talk about intravenous ketamine, an evidence-based approach. I am professor at the Department of Psychiatry at Queen's University and researcher from the Center for Neuroscience Studies at Queen's University in Kingston, Canada. This is my disclosure. I am not involved in any research activities funded by the manufacturer of ketamine or esketamine, but I receive honorarium as a member of advisory board and speaker from Janssen Silag on esketamine. The content of my presentation is basically synthesized in two papers I am co-author. One of them is a publication recently accepted at the American Journal of Psychiatry, which is about ketamine and esketamine in the treatment of treatment-resistant depression, bringing an international perspective that I believe is going to be interesting for you. And also an article recently published at the Canadian Journal of Psychiatry with the CANMAT recommendations for the use of racemic ketamine in adults with major depressive disorder. These two publications are very good if you want to find information in a reliable publication. Both of them are very good options. Well, why talk about ketamine is important. In my everyday practice as a psychiatrist, I see lots and lots of patients with depression and also with bipolar disorder, mood disorders in general. And even with, the several options that we have in terms of medication, neuromodulation, and evidence-based psychotherapies, the medications we have available so far still are limited in provide to our patients remission and relief. I think our patients deserve better. They deserve more and better options than the monoamine-based antidepressants that we have available so far. And it was interesting to see that, especially by the end of the 90s, the involvement of a different system, the glutamatergic system, became more investigated in depression. So, for example, we started to see studies suggesting that the MDA receptor was involved in pathophysiology of depression. This data coming especially from preclinical studies, but also from data from studies involving conventional or monoamine-based antidepressants. In 2000, we have this pioneer study conducted by Borman, which is a member of John Crystal's group, which was a small randomized controlled trial involving only 9 individuals randomized to receive IV ketamine or placebo. And this small trial showed a very, very different response in the two groups. The authors were able to show that the individuals who received IV ketamine exhibited a very fast decline of severity of depressive symptoms evaluated by a conventional instrument like Hamilton Depression Rating Scale. And as expected, those receiving placebo didn't have any significant change in the severity of depression. This small publication, this small study became a publication in Biological Psychiatry, and it opened, the door for several different studies that I'm going to comment with you today. We should say that ketamine is understood as an MDA antagonist. Ketamine is used off-label. It is not approved by FDA, for example, while development of this medication, which is esketamine, is the S enantiomer, is approved by FDA, Health Canada, and is also approved in 28 European countries for the treatment of treatment-resistant depression. We have RCTs, which are the base for the use of ketamine and esketamine in the treatment of depression, unipolar and bipolar, but especially unipolar. But it should be said that there is a low probability that we are going to see large RCTs on ketamine, mostly because this product is no longer protected by patents. So it's not profitable to conduct clinical trials with ketamine. In spite of this, the off-label use of ketamine has been widespread. So it's possible that we are going to see much more studies evaluating its effectiveness instead of studies focused on efficacy. This widespread use and concerns with what's going to happen after, concerns related, for example, to the possibility that people get ketamine to be self-administered at home, or doubts about where is the best setting to provide this kind of treatment. Should the patient be treated in a hospital? Is an outpatient facility okay? So it made the CANMAT to create a task force on ketamine, which resulted in a paper, with the first author is Jennifer Swanson, recently published it. It's one of the papers that I showed you in the beginning of this presentation. The content of this presentation will be basically based in the experience of the Canadian Rapid Treatment Center of Excellence, which is led by Dr. Roger McIntyre in Mississauga, and also the ketamine clinic from Providence Care Hospital here at Queens, which is led by Dr. Gustavo Vasquez. The two publications I show you, and also a consensus that the American Psychiatric Association released in 2017. I divided this presentation in 10 critical questions that are important to be answered by us if we decide to prescribe, use, and incorporate IV ketamine in our clinical practice. The first question is naturally, what is ketamine? What is this medication? Ketamine is a medication traditionally used as an anesthetic, and is a drug with multiple mechanisms of action. Although we consider that an NMDA antagonist is the most important mechanism, ketamine also has several neuromodulatory actions. Ketamine blocking the NMDA receptors, ketamine reduces the GABAergic activity in the prefrontal cortex, especially in the prefrontal cortex. So this has been postulated as being the main mechanism for the antidepressant action of ketamine. But as I mentioned to you, ketamine was also able to provoke epigenetic changes which are related to modulation of synthesis of different proteins, especially BDNF, which has been considered the main neurotrophic factor and the main mediator in provoking changes in neuroplasticity that we see in depression. We should also say that ketamine has an action over opioid system. And the reason why this is important is because a small RCT with naltrexone demonstrated that when we have a patient taking naltrexone, it's going to inhibit the antidepressant effect of ketamine. And that's the reason why if we have someone that we are, prescribing IV ketamine as a possible treatment, we always discontinue naltrexone use. If the person is trying, for example, to stop drinking, this can be a good option. What's the pharmakokinetics of ketamine? Ketamine can be used with multiple routes of administration. We can use it at intravenous, intramuscular, oral, subcutaneous, intranasal. So we have several options. Of course, the IV is the route with the highest bioavailability, more than 90%. It should be given to the patient in a slow infusion, which is usually over 40 minutes. And the IV administration has a very solid evidence of efficacy. It is related with a rapid diffusion to the brain. Ketamine is metabolized, especially to more ketamine, by enzymes from the CYP system, and is totally eliminated in 24 hours, although some metabolites can be detected in up to 3 days. Esketamine is the S enantiomer of ketamine, so we have the racemic ketamine, and we have the, which is a mix of two, and we have purified esketamine. Its intranasal use was developed by Janssen, and we don't have good data comparing IV ketamine and intranasal esketamine. These are different drugs. What we have in the literature is one small non-inferiority study, but in my interpretation, we don't have enough data to say that intranasal esketamine has the same action of intravenous ketamine. It should be said that when we use IV ketamine, we have, a very strong control of how much drug we are giving to the patient. And that if we have like a side effect, we can just turn off the infusion and the effect will be gone very soon, because the metabolization of ketamine is very, very quickly, which does not happen with intramuscular, oral, and other routes of administration. So sometimes even the patient can think that having a PO medication is safer than having an IV medication, but this is not necessarily true. When we take a look in the effectiveness data, we can ask ourselves, what is the effectiveness of ketamine in the treatment of unipolar depression? We have so far 8 meta-analyses, all of them conducted in the past 5 years, summarizing the results of placebo and active controlled RCTs. What we know so far is that a single infusion of IV ketamine has a powerful antidepressant effect that peaks in 24 hours and lasts 3 to 7 days. This is evidence level 1, so very, very strong evidence. If we give only one dose to the patient, the average time of relapse is 10 days. And regarding this, it should be said that these data come from small samples, most of them with crossover design, most of them conducted in the beginning of the studies with IV ketamine, with a follow-up which is limited to 1 week. Only 2 RCTs followed patients for more than 30 days. And these 2 studies show sustained response of 45% and 19%. When we take a look in what's the dose used by most studies use a dose which is 0.5 milligrams per kilo. Higher doses were not more effective, and lower doses were ineffective in 2 RCTs. Different centers have different protocols. So for example, CRTC, if the patient does not respond to a lower dose, they give a dose which is slightly higher. But the support we have from the literature is 0.5 milligrams per kilo. What happened when we give ketamine for, more times, repeated infusions? Again, different protocols. The minimum number of infusion is 4 to 6. We have a large series of cases from China with unipolar and bipolar depression, showing that 6 infusions are enough to produce response in 60% of the patients and remission in 51%, which is really good, considering that most of the patients are resistant to other antidepressants. The same patterns were seen in other open label studies, and I would like to talk specifically about this study, which is my perspective is very interesting. It's a study from UNESCO, it's an RCT with 26 patients that couldn't find any difference from placebo. But it should be said that UNESCO included in the study only ultra-resistant patients, which are those which did not respond even to ECT. So the level of evidence that we have for repeated infusions of IV ketamine is 4. 4 means that we have pilot studies, uncontrolled trials, anecdotal reports, and expert opinions. So it's more fragile than the level of evidence that we have for the acute effect. When specifically we think about bipolar depression, we should say that most data come from studies involving both unipolar and bipolar depression. Very few studies specifically analyzed what happened in bipolar depression. One open label study from Rybakovsky found 51% of response. And interestingly, we have data showing that cognition can improve in patients with bipolar depression. Dr. Joshua Rosenblatt from University of Toronto and the medical director of CRT-ECC is conducting at this point a clinical trial with IV ketamine for bipolar depression, which is a very important study, and I think it's going to give us, critical responses regarding this topic. Well, then we can ask ourselves, okay, we know that ketamine works very fast, but what are the benefits in the long term? First benefit, is it possible that ketamine can somehow prevent suicide? This is something that we want to know, because as we know, even with all these 20, 30 antidepressants that we have so far, the rates of suicide are basically stable in the past 30 years. So we need interventions which are able to reduce suicidal rates. There is a potential in ketamine to reduce suicidal ideation. Ketamine has shown to produce a rapid reduction in suicidal thoughts, which is not totally dependent of the improvement, the global improvement of depression after a single infusion. But we still need to be more careful when we analyze this data. And I think this is a call for those who are working with ketamine to better, dissect dimensions of symptoms. And I'm specifically talking about perhaps adopt an RDoC approach in terms of taking a look in specific clusters of symptoms. Another thing that sometimes people ask me, what's the potential of ketamine in change the course of illness? If we have someone, which is chronically depressed, we know that this is related with neuroplastic changes in the brain, that, the brain is going to shrink, that we are going to have an increase of the volume of areas occupied by liquor. So would it be possible that ketamine has a benefit in the long-term course of illness? We don't have this response yet, but we can hypothesize that this is a possibility. Because as we know that the number of episodes is a predictor of poor functioning in mood disorders in general, in a concept that Kapczynski and collaborators call neuroprogression, it's possible that reducing the chances of relapse, we can indirectly change the course of illness. But what about side effects? We are talking about the good side. What about the bad side? We basically have two groups of side effects that we have to pay attention. One of them is more from the psychiatric side, and the other one is more from the general medical side. From the psychiatric side, the main concern is dissociative symptoms. So usually patients tell us things like, I can hear the sounds a little bit different, a little bit distorted, or I can hear that nurse typing in the computer the whole time, or your voices are different, sometimes things different or weird in their bodies. I feel that my body is heavy, or that I am too light, or that my organs are moving differently. This kind of mild dissociative symptoms, they rarely persist for more than 1 hour, and they usually do not require any intervention. If they are very uncomfortable for the patient, we can just interrupt the infusion and the symptoms will be gone in a few minutes. But it should be said that knowing that this could happen, we should prepare the patient for the dissociative symptoms. And it should also be highlighted that some authors are starting to describe that perhaps the presence and the intensity of dissociative symptoms could be related with the chances of response. So actually having a dissociative experience is not that bad. And some authors are even hypothesizing that perhaps instead of giving the ketamine in a 40 minutes infusion, we should try to prolong the dissociative experience and give them ketamine, for example, in 60 minutes or 90 minutes, trying to, make the infusion slower than the protocol that we are actually adopting. The second group of side effects is related with cardiovascular side effects, especially with increase in the blood pressure. The results that we have so far are very heterogeneous in terms of quantifying and give us a good idea of what's the risk of increase in blood pressure. When we take a look in the magnitude of the effect, there is an average increase of 3 milligrams of Hg in systolic or diastolic blood pressure, which is, even that the risk to increase blood pressure happens in a not neglectable, proportion of patients. We are talking about, something like 15%. When the blood pressure increases, it's not that much. A large study showed this only 9% of the patients. Heart rate can increase a little bit. Drowsiness and other symptoms are relatively common side effects: blurred vision, nausea, vomit. Nausea can happen, headache, poor coordination, poor concentration, or restlessness. And this is the reason why we keep the patient under observation after the end of the infusions, and we release the patient home only with the presence of a family member or a friend to be with the patient for the rest of the day. What protocol should I use to administer ketamine? Let's say that you guys are planning to start a ketamine clinic. What protocol you should adopt? We have more than one protocol described in terms of number of infusions, dose, and how to introduce the medication. And we don't have enough data to say that one protocol is better than the other because they were never compared head to head. The protocol we have at Providence Care Hospital here in Kingston is 10 infusions in total. So we consider that a course of treatment is 10 infusions. In the weeks 1 and 2, the patient will receive 3 infusions on Monday, Wednesday, and Fridays. In the week 3 and 4, 2 infusions in Mondays and Fridays. The dose, as I mentioned, is 0.5 milligrams per kilo, infused in 40 minutes, plus a minimum of 30 minutes of observation. We have the intranasal option to give the patient esketamine. Why should I use IV ketamine or esketamine? Are they the same? Can I offer the 2 options to the patient? So first, they have something in common. They are both treatments for TRD, treatment-resistant depression, and they are both rapid action agents. Both require supervision in administration. Esketamine even being, simple than give to the patient because it's intranasal, should be done in the presence of a doctor or a nurse in a clinical setting. Ketamine is IV, has a higher complexity, but on the other hand, the medication has a very low cost. Ketamine is very inexpensive medication. The high cost is in administration. Esketamine is intranasal, then administration is related to a lower complexity, lower cost of administration, but higher cost of medication. This is still a very expensive medication. I'm not sure what's the price here in Turkey, but it's expensive. We have better quality of evidence from experimental studies for esketamine, but we have more experience with IV ketamine in real life. So both of them have advantages and disadvantages. If I'm going to start a ketamine clinic, what settings and what personnel are required to give a ketamine to someone? Ketamine should be given to a patient in a facility with cardiovascular and respiratory monitoring and rescue medications to manage both psychiatric, which is basically dissociation, and medical side effects, which is basically cardiovascular side effects. The facility should have ACLS trained personnel, and in most jurisdictions, a physician will be the responsible person. Of course, there is a variation from one country to the other. Some places can admit that a nurse can be, the most responsible person, but most of the countries, and here in Canada, in all the provinces, and it's the same for US, the most responsible person is a physician. Then the question, should this physician be a psychiatrist or an anesthesiologist or a critical care physician, or it can be a family doctor? Specific sites have, specific roles. And we always suggest that to prevent medical legal issues that you consult your local authority to make sure that the team you are creating is enough qualified to provide this treatment to your patients. The evidence that we have for the composition of the teams, again, is level 4. We don't have any study testing if there is any difference in having a psychiatrist or anesthesiologist, and what should be the composition of the team and the level of complexity of the facility. And finally, what's the future of ketamine and esketamine in the study of treatment-resistant depression and also in bipolar depression? We have so far very robust data on short-term efficacy of IV ketamine, but we have limited evidence for long-term efficacy. So I would like to see studies showing me what's the impact of giving this treatment and the course of illness with the time. Is ketamine an anti-neuroprogression medication? I would like to see this data. I also would like to see studies comparing ketamine to other interventions for TRD, especially with ECT, because this is a question that sometimes patients ask us. Should I go to ECT or should I try ketamine first? And we actually don't have a clear response or an evidence-based response to say what intervention should come first in the algorithm of treatment. It would be very interesting to start to use more and to see more incorporated in clinical care, the stratification of levels of resistance in depression. We call TRD any patient who did not respond to at least 2 different antidepressants, but it's very different when the person tried 18 antidepressants and ECT and TMS and didn't respond. It's a different level of resistance. I would like to see data showing that ketamine is or is not able to provide an effect in terms of relapse prevention. And finally, ketamine paved the way for a number of studies to investigate different mechanisms of action and to develop me-too strategies. So now we know that glutamate is a critical target. So we can investigate other medications that will modulate glutamate. Now we know better that neuroplasticity is a critical target. So we can explore other interventions that has neuroplasticity as the main target. If you want to learn more, we have this book from Vasquez Zarate and myself, which is edited by Elsevier, is a manual approaching ketamine for treatment-resistant depression. And I would like to thank to Queen's University, specifically to Dr. Vasquez and Melody Kang from the Ketamine Clinic, my colleagues from the CanMat Task Force, and Dr. McIntyre, Rosenblatt, and Lee from the CRTCE in Toronto, This is my email. I'm happy to provide answers for your questions with the best of my knowledge. Thank you very much. It was a pleasure to be with you.